Greetings, everyone. Today we have a very special virtual morning report with Dr. Laila, and this is a special IG. It's also special because there's the fact that it's the birthday of our dear friend, Kushal. Please send him a warm birthday. He's really special to this community. He's always here with us, and we're really thankful for him to spend time with us today. So maybe I can introduce our guest. Dr. Laila. Dr. Laila, she did her medical school at the Universidade Francisco Marroquin, Faculdade de Medicina, and then she did her fellowship in the USA at Case Western Reserve University School of Medicine. She did her fellowship in infectious disease over there. And also, Dr. Laila, she is an attending physician on infectious disease consultation service at Emory University Hospital and Emory University Midtown Hospital. And she provides outpatient service at the Emory Healthcare Infectious Disease Clinic. So thank you, Dr. Laila, to be with us again.
Well, thank you for inviting me. And, and before we start, happy holidays to everybody, because we're starting that season.
Exactly. So maybe now, Madalena, could you please introduce yourself?
Yes. Hi, everyone. My name is Madalena Conti. I'm currently a third-year medical student in New York, and I have tuned into many VMRs but have yet to present a case. So I am extremely excited to be here, excited to present to Dr. Laila, and just happy to be here.
Awesome. Maybe Kara, can you please introduce yourself?
Yes, of course. Hi, my name is Kiara. I just graduated this year from med school. I'm happy to see Dr. Laila again, so I'm very excited for today. And also, happy birthday, Kushal.
Please, Maria, go next.
Hi, friends. My name is Maria. I'm from Guatemala. I'm also a medical student, and I'm really thankful for being here with all of you. Thank you, Dr. Woc, for joining in, and happy birthday, Kushal. Best wishes to you.
So Madalena, whenever you're ready, we can start.
Okay, so I will get started. Before I do, I just wanted to clarify, should I call you Dr. Laila, Dr. Woc, something different? What do you prefer?
So I either go, so in Latin America, we go by first name. So we go Dr. Laila, or you can do my what everybody knows me in as Doc Woc. So
Doc Woc. Okay.
Yes,
that's amazing.
That has stayed for me for many years. And
Doc Woc.
of course, that is also my Twitter handle and my handle for a lot of things. But people know me as Doc Woc here in the US, and then if you want to be more personal, Dr. Laila is fine. So
okay, wonderful. So I will go ahead and get started. So just as kind of an overview, I'm going to present the case over 4 aliquots, and then hear your analysis in between. So I'm going to start with just the chief concern and a brief of the portion of the history of present illness. So the chief concern is, in the patient's words, my left hip hurts. And to give you a little bit more information, this patient is a 21-year-old man with no significant past medical history, who presented to the emergency department in New York with acute left hip pain that started 2 days prior. He was in his normal state of health until 2 days ago, when he noticed what he described as a throbbing pain in his left hip. He initially thought it was a sprained muscle because it felt similar to this right groin pain that he had after a snowboarding accident 8 months earlier. However, his left hip pain worsened over the next day to the point where he could no longer bear weight on his left leg, and he was limping around the house. It began to impact his life to the point where he could not attend in-person college classes the day before he presented because of difficulty walking from the pain. He took 1 Tylenol with no relief, so he decided to come to the emergency department. He describes the pain as constant, throbbing, non-radiating, and exacerbated by any kind of movement. He denies any recent trauma, joint swelling, fatigue, rashes, or any bug or insect bites. He did state that he was visiting his uncle in Eastern Long Island, New York, about 3 months ago, who has a large backyard with ticks and migrating deer, but he never noticed any joint pain, rashes, or insect bites after that outing. And that's the end of the first alquat.
Okay, so this is interesting. So, okay, and this is only the left hip. So it's a
Only the left hip.
monoarticular. So we have a 20-year-old man with monoarticular hip pain. So first of all, being ID, so, infectious versus non-infectious. So the two famous buckets, right? So in the infectious bucket, I would put STDs, so sexually transmitted diseases. So HIV, gonococcal, chlamydia, even syphilis, but those will be your STDs. And he's 21-year-old, was happened, goes to school, and we're in an endemic area. So I would do the STD, and the most common prosthetic joint infection, in STDs would be gonorrhea. The second part I would put, you would say other bacterial. So, he had the ski accident. It's a little far. Sometimes we can have some, some linear fractures, and you have kind of things like P. acnes and staph epi that can happen. But we see that's more in the older population and prosthetics. Then you mentioned, this is kind of the red herring where we like our things is that, it's New York. And just like today, I saw someone who they claim to have Lyme. So you have to put that on your Burkhardia in there because you're living a Lyme. Even though you don't remember a tick, most people don't remember ever being bitten by a tick or find ticks on themselves. So I would put that as the zoonotic part tie-in would be that. Less likely fungal, less likely parasitic, and less likely viral. The fact that you said that he has no past medical history is good. We see avascular necrosis in sickle cell patients. And so that would be something that would prompt up there. So I would, do it the infectious and then non-infectious part,
Incredible. I love kind of the way you initially broke it up into those, two big buckets and expanded from there. Okay, so moving on to the second aliquot, where I'll give you a little bit more of the review systems and some past medical and family history and social history. So in terms of review systems, the patient denied any headache or blurred vision. He also denied any cough, chest pain, palpitations. He denied any nausea, diarrhea, vomiting, or any kind of constipation, abdominal pain. He also denied any dysuria or change in his the color of his urine or the odor. When asked more about this pain and any other joint pain, he did say that since the pandemic began, he's been working more on his computer at home. He has noticed more of this bilateral wrist pain that he really feels after studying, but he doesn't know if that's related. No, he also denies any kind of excessive sweating or cold or heat intolerance. So in terms of past medical history, as mentioned before, he has no chronic medical conditions. When you review the chart, you do see that he's had a few emergency department admissions, one for acute otitis media, one for viral gastroenteritis, one for the snowboarding accident that he had, but no other chronic medical conditions. He also has had no past surgical history. In terms of family history, he states that his younger brother was diagnosed with juvenile idiopathic arthritis 3 years ago and is managed with daily etanercept. He also reports that his father, actually when interviewing this patient, he was with his father. And so when you asked the father what his history was, he said that in 1996, he had an episode of joint pain that in his words was worked up as either rheumatoid arthritis or viral arthritis, but he can't remember more details than that. In terms of his social history, so he was born in New York and he is currently a college student. He's a computer science major, so spends a lot of time on his computer. He is sexually active with one female partner and reports consistent condom use. He states that this one partner has been his only partner in his lifetime and denies any kind of issues with sexual function. He also denies any prior sexually transmitted infections. He reports to drinking about 2 times a month with socially, and he denies vaping, tobacco, marijuana, or other drug use. Besides the trip to his uncle's house 3 months ago, he denies any recent international travel, sick contacts, or interactions with pets. No known drug allergies, and he takes no medications. So lastly, I'm going to go through the physical exam. So in terms of his vitals, his temperature in Celsius was 36.7 with a T max of 38.4. Blood pressure 124/66. Heart rate was 76, but it ranged between 76 and 113. Respiratory rate 18, and he was studying 98% on room air. In general, when you look at him, he appears to be a young man in pretty moderate distress, holding his left hip because of the discomfort. His conjunctiva and sclera are clear, moist mucous membranes, no oral lesions that you notice. The neck is supple and no noticeable lymph nodes. Lungs clear to auscultation bilaterally, unwavered respirations, no wheezes or rhonchi. Heart S1, S2 present, no murmurs or gallops. Abdomen soft, non-tender, non-distended. And no suprapubic tenderness. For the musculoskeletal exam, you do note there's of course arthralgia of the left hip. There's moderate tenderness to palpation, but you don't appreciate any redness or swelling when you look at it. It is, when you do kind of attempt the range of motion, it's limited because of the discomfort, particularly with flexion and extension of the hip. As I said, you don't notice any joint swelling. And in terms of the other joints, there's no other swelling of other joints. So the bilateral knees and hips are without swelling or warmth. For the extremities, 2+ peripheral pulses in all extremities, no edema, and no rashes, ecchymoses, petechiae, or nodules that you notice.
Okay.
And that's the end of the second aliquot.
Okay. So so there's a couple of things. So one of the things to ask is how many acute otitis medias has he had, or sinusitis has he had throughout his life?
That's a great
And the
question.
Go ahead.
It was just that one episode that he described.
Yeah. So when I hear, he's a young man, and what you're looking for, as Kushal said, is sometimes recurring stuff, looking for immunodeficiencies, but that would be a side step. So let's focus on what you have here. You have a 21-year-old man who actually has a fever. So that's the first thing. And from the description of your range of motion, he has, to proven otherwise, he has a septic joint. And the reason when you evaluate a joint is that if you don't have the range of motion, there's definitely some inflammation, or it could be purulence or crystals inside the synovia that is not making you be able to move it up and down. So for example, on the knee, or like you have the knee and you're not able to move, or sometimes you're able to move, you have more of an inflammation on the patellar bursa, and that is not a septic arthritis. But here you say that you try to lift it up, do external rotation as well as internal rotation, and probably push it up, and that was limited because of the pain, correct?
Correct, exactly.
So fever, limit range of motion, tenderness when you palpate, Sometimes plus or minus, you might have redness around that area, depending on how much the purulence or the inflammation fluid is around. That will give you part. It's usually a very focused exam when you have this. So it is. And then when you examine the rest of the joints, you didn't have anything else, correct?
Yep, that's correct. No kind of swelling or tenderness or redness of the other joints.
Okay. So putting it together, so we'll put the, it has immunodeficiency kind of on the lower part, but right now it is looking like a 21-year-old man who has a septic left hip that is acute because it started 2 days ago. We might have some red herrings. He had a snowboarding accident months ago. He had some, went up hiking up in the New York State. So those could be some risk factors, but really not playing too much because it seemed to be an acute part. Also, when you describe the pain, the fact that there was no relief with Tylenol, which is an anti-inflammatory, tells you that there's something more going on. So then I would say, well, how do I evaluate acute septic joint arthritis onto proven? So one thing is definitely is putting a needle in. So you call ortho or call room, usually it's ortho, and do an arthrocentesis. Initial labs that you can do that might be helpful. You could have an elevated white count, an elevated CRP. I'm not a believer of set rates, and the reason is that costly wise, they're more costly, and there are fluctuation depending on your age and chronic conditions. So a set rate, you get blood, you have to put it on a thing that measures 100 centimeters, and you let it settle down during an hour. And where you see the pack of red cells, that's the sedimentation rate. So when you look at cost analysis, it costs more, takes more time, and doesn't give you a lot of information. While the CRP does in this case. So that would be the inflammatory marker that would check. And then I would ask, ortho to put a needle. And so if I have to, those would be my minimum amount. You can do an X-ray of the area. It might show some, like if you had, it was trauma, if you had a fracture, it would be very hard to see. Usually if you want to have more finesse, and we do this when there's more kind of chronic or prosthetic part, is doing a CT scan where you could see that, but that would be more costly and it will take more time.
Great. Okay. So in this next outcrop, we will definitely get some of what you asked for. A quick question for you. So if you were, in the emergency department, you had this information, how would you think about empirically starting any medications, and would you or would you not?
Yeah, so in the emergency department, after I get my initial labs, so I would not start any medicine until I get an arthrocentesis. Because I want to have the highest yield of into that fluid, and we're talking about small fluid. So I don't want to give an antibiotic that is going to, mask something. So for example, strep, if it gets a whiff of antibiotic, it dies pretty quickly, and I'm not going to be able to know that. So I would try to get my blood work, including, including STDs and HIV, and try to get the arthrocentesis. I mean, he's febrile, he's not able to move. If you tell the ortho to come by, they will evaluate and tell you if actually the joint is septic or not. They'll be able to maneuver it. And if they do, that would be, once you do the arthrocentesis, you can start antibiotics. He has no past medical history. He hasn't been around. So vancomycin, ceftriaxone would be kind of your starting one to cover MRSA, and the ceftriaxone will cover your strep, and it will cover your E. coli and other things. And actually, it does have some treatment against gonococcal, which I think we might go through that.
Okay, great. So I'm going to go through what ended up happening, maybe not necessarily what the perfect course of action would have been. So in the emergency department, he was given the following medications. He was given IV morphine, 4 milligrams, a fluid bolus. He was given Tylenol, ibuprofen, and he was given vancomycin and ceftriaxone before the rest of these tests were done. During the vancomycin infusion, he did develop itching and a diffuse rash on his neck and back during the vancomycin infusion. He did not have any chest pain, respiratory stress, or stridor during the infusion, and his vital signs remained stable.
Okay.
The team spoke with the patient and the family about this reaction and their preference on reducing the rate of future infusions versus switching medications. And with the family and the discussion, they decided to continue with vancomycin for that coverage rather than switching medications.
So he had a vancomycin flushing syndrome. Because we don't call it Redman syndrome anymore, right? Because it's not PC, and so it's called vancomycin flushing syndrome. So just, you know, to be more political correct, or infusion-related rash.
Exactly. Okay, so here's some of the objective data. So in terms of the white blood cell count, that was 8.08, hemoglobin 15.2, hematocrit 44.8, MCV 85.8, platelets 148, sodium 136, potassium 3.9, chloride 101, bicarb 23, BUN 16, creatinine 1.01, and glucose was 119. AST 14, ALT 14, ALK phos 57. The PTT was 30.3, the PT was 15, and the INR was 1.26. CRP was sent, which came back at 42. And I do have some imaging findings as well. So an X-ray of the left hip and femur were obtained, which showed no acute fracture or dislocation. The impression of the imaging also stated no advanced arthritic changes and no associated cortical destruction.
Mhm.
A CT abdomen and pelvis was also sent, and that noticed a left hip fluid collection measuring 1.3 times 5.3 times 6 centimeters. The impression stated no evidence of psoas absent, no evidence of psoas abscess or extra-articular extension. And as well as synovial fluid analysis was taken. This was actually the next day. So just to give you a little bit of timing, and as a reminder, the antibiotics were given in the ED. And the synovial fluid analysis showed cloudy fluid appearance.
Okay.
The total nucleated cell count was 135,000. Total red blood cell count was 11,900. The segmented granulocytes or neutrophils was 92%. Monocyte or macrophage count was 8%, and no synovial crystals were identified. Okay. And that's the end of the third aliquot.
All right. So so you know, part of doing you know, the virtual morning report is trying to figure out how you can do things in an efficient manner and also not to waste too much healthcare costs, you know, because each thing. So just the physical exam told you that there was something going on the hip, right? And so the appropriate, so if you had to choose 2 tests to be done, would have been, you know, put a needle into it and, you know, and then, you know, do your CBC and your BMP. I don't know why they went with the LFTs because none of what were related is liver. You know, I mean, he's not septic, there's nothing like that. So that would have not done that. And then they decided to, you know, do the image that is becoming standard, which is the CT. And, you know, you know, you had the left hip fluid collection, which, you know, it's the synovial, which you already knew that because you had limited range of motion, right? So now, did you say that did you mention a set rate or CRP on your labs?
Yep, a CRP was sent, and that was 42, which was elevated.
Yes. So anything about so So anything above 10, if it's liters, and if deciliters is 1, so that is also tells you that there's inflammation. And then definitely your fluid collection, you said that was more than 100,000, right? And 100,000 on WBCs goes more towards a septic purulent part. It would have nice if they were done when they did the crystals, if they're done a gram stain to see if there was any GPCs or gram negative diprococci floating around there.
Yeah, that'll come in the next aliquot.
Oh, well, see, I would have taken, well, now I can't take it because my hospital doesn't let me do my gram stains in the hospital. That's a different story. But the idea is that you get the pus, you go to the lab, do the gram stain, and there's the aha moment. So things that I would have not done, probably the CT, the liver function test, definitely the creatinine is fine because you're starting antibiotics and you want to make sure it doesn't have like end-stage renal disease. I don't know why, but and then go from there, right?
Yeah, no, thank you. I think it's helpful to hear not only your thought process on the differential, but also, the specific, being very intentional about the test that you're sending, and not sending a test that you already know the answer to. So that was helpful to go through.
Yeah, the poor guy already has a bill of like 20,000 in the ER.
Yeah, right. Especially in the US. Yeah.
Yes.
Okay, so this next aliquot will be the last aliquot of data, and then I'll kind of ask you at the end how you would think about management after that. But I guess at this point, I kind of wanted to ask you talked a little bit about some of the infectious part of the workup you would want to send. Anything else you would want? How else would you kind of work up now that you have the synovial fluid analysis?
So I still will still check HIV, and I will still take JC and chlamydia, because JC and chlamydia can give you this, and actually this will come if it was a recurrent patient. There's things like mycoplasma that is also genitalium, which is transmitted sexually, that can actually cause recurrent joint infections. So would I get blood cultures? Yeah, we can get blood cultures. Since it can be spread hematologically. Yes, it would have helped that if the blood culture is like a staph, definitely then I have more of an issue that this is like an endocarditis kind of seeding and things like that. So yes, so blood cultures are part of the workup initially also. So yeah, thanks, Kusho. But definitely have HIV, JC, chlamydia, have anaerobic and the gram stain. Something to know as we go forward is that now we have rapid tests like BioFire, which actually have which has joint fluid PCRs. So you can actually get an answer in the ER in 15 minutes once you stick the needle, take this thing to the lab, and they join that. It reads to about, I think, about 10 different organisms. So, and also have something called alpha defensin. So alpha defensin is elevated in joint infections, and it's very useful, especially when we have prosthetic joints.
Interesting. Wow, I wasn't aware of that rapid test. That's very interesting.
Yeah, I mean, obviously, all these rapid tests have a price, but I can tell you it's cheaper than the CT abdomen.
Yeah, yeah, I believe that.
So the other thing is that I'm worried. So there are some septic arthritis that you actually need to take and wash. Have ortho do it. So not having ortho involved at the beginning in the ER can lengthen delay your treatment and increase your length of stay in the hospital.
Got it. So great. I'll move on to the fourth aliquot. So the patient did actually get a washout from ortho. And I'll now go through some of the kind of infectious and immunology workup that was sent. So blood cultures were sent. There was no growth. For the synovial fluid cultures, there were no organisms seen on gram stain. There were just the polymorphonuclear leukocytes that were seen. In terms of I'll start with the kind of immunology and room workup that was sent. So CCP antibody was sent, which was negative. There was an ANA, which was also negative. The Lyme test was negative. They sent an IgG, IgM. Rheumatoid factor was also negative. In terms of the infectious workup, I'm just scrolling down here. So parvovirus, IgM, and IgG were sent. The IgG was 7.37, elevated. The parvovirus IgM interpretation was negative. I already mentioned the Lyme, which was negative, and the GC gonorrhea chlamydia amplification result was also negative. So that is the last aliquot of information. At this point, I'll tell you that the patient had been in the hospital for about 2 to 3 days, was on the same antibiotic regimen, and the pain was very much improving to the point where the patient was able to walk out of bed or stand up and ambulate much easier than before. So with all that in mind, I would love to hear your thoughts on that, kind of that last workup. And then also at this point, how would you think of the management of the patient?
Yeah, so you know, I mean, as we talked, you know, getting that initial antibiotic there, like strep, will, you know, definitely have your culture negative. And this is where I do rely on this PCR BioFire, because it's able to pick up little parts, especially if I don't want to end up with a culture negative septic joint, like this is happening. So there was a question about anaerobes. The anaerobes that we usually find in septic joints that we worry about is P. acne or Propionibacterium acne, and that one is covered by vancomycin. So you don't need to add anaerobic coverage to a septic joint in this case. So I just don't forget. So I'm surprised that they went with I guess a rheumatological testing, you know, and I guess it just depends on the history that he was given, but this acted very much like an acute event. As I said, he had the upstate New York travel, so the Lyme was going to be checked, you know. The part was interesting because the hemoglobin did not drop. So parvovirus, one of the characteristics of parvovirus is to have low hemoglobin, so a aplastic anemia, right? And you don't have that, so it's an expensive test. It takes you about 5 to 10 days to get it back. So that would have not kind of been on my radar, and you know, and so I would think that there's things that we can rule out is that doesn't have MRSA, because MRSA would have grown, as well as MSSA, but things that you cannot rule out are strep. You cannot rule out, you know, P. acnes, or the new name that is Cutibacterium acne. So this patient would go with a culture negative treatment of 4 weeks, which usually includes ceftriaxone or, you know, vancomycin.
Okay, yeah, that was very helpful to hear. So I'll kind of give you an update on the patient now. So, well, I guess one last question. So if you were to discharge him, if he his symptoms improved and he was ready for discharge, would you send him home on antibiotics, given that no clear infection was found, or how would you manage that?
So one question I didn't, when the orthopedist went in, what did the OR note say? What did they find when they went in?
When they cleaned the wound? So let's see, I don't have the note right in front of me, but so they cleaned it out, and when speaking with kind of the doctors involved with the case, they were very concerned about a psoas abscess, which I think was actually part of the reason why they got the CT scan. And I'll have to pull up the note here, but I believe that the gist was that no psoas abscess was found and it hadn't extended beyond the joint.
Okay, so the reason I always like to read the OR notes in details, because the surgeons, you're never going to find them. That's always the issue, you know, unless you're around at 6 o'clock in the morning, you're never going to be, and you're not going to be in surgery looking, but the OR note is very detailed. So it goes into it and it tells you how they approach, what they saw, what the fluid looked like, if there was inflammation, was there necrosis, was there purulence, did they go into the joint, did they open the joint, was it a clear, murky, was it a gelatinous type of part? So I make an emphasis to my team, especially when we have these cases, to read, or any case that has surgery involved, to read the OR note, because you'll miss details. For example, one of the sponges fell to the floor and then we picked it up. You broke the barrier or something like that, or you know, the count wasn't complete. But it gives you extra information that you won't get from reading the progress note, because the progress note is going to be short and concise and might be copy forward, right? So what you want, where you get the most information is your OR note. So I make a detailed reading the OR note and then pointing out where they found those things. That helps me a lot, and because they put a lot of detail there. So as you go forward in your career, reading the OR notes are a must, especially, you know, it will tell you. If you have necrotizing fasciitis, it will let you know when they finally found that there was no more dishwater and it was clean, right? So,
yeah. Okay.
So going back to the patient, would I send this patient on antibiotics? And the answer is yes. I would do vancomycin, an IV option for 4 weeks. If you don't want to do oral options, the Oviva trial, which came out a couple of years ago, is using oral versus IV. So I would use like an oral. So Levaquin, levofloxacin has very good coverage for strep and gram negatives, and associated with Bactrim, which will cover your MSSA and your MRSA. You could also do, so for those that, you know, so they're not doxy deficient, we'll do levofloxacin doxy. Moxifloxacin doxy is another combination. These are oral, so you don't have to put a PICC line into those patients. But his sedimentation rate, his inflammation fluid, and everything points towards an acute septic arthritis. Now, what I worried is and he didn't get did he get an HIV test or just a JC chlamydia?
He just got a JC chlamydia, actually.
HIV.
I know. I mean, I think if we could all rewind the clock.
You know.
Yeah.
I'm sorry, I'm jaded. I don't believe like they just have monogamous relationships. Sorry. Like, I've seen too many of those floating around here. So one of the things I worry is, for example, mycoplasma, which is a sexually transmitted, and we're seeing more of those, and those will be your recurrent ones. And those are hard to grow. Those won't grow on your cultures. So they have to be actually sent to a specialized lab like Mayo to have the mycoplasma, or in University of Alabama where they study mycoplasma. So, but that would be, you know, more of a recurrence part. Okay. So yes to antibiotics 4 weeks, and then, you know, follow up and see how it goes.
Okay, great. So I'll give you a little update. So in terms of the ID colleagues who were following this case, they changed his antibiotic regimen to Levaquin, as you said, 500 milligrams PO on discharge. Their reasoning was that kind of no clear infection was found, so the antibiotics remained empiric, but exactly as you said, the suspicion was very high. And the patient, of course, was discharged, and his pain had resolved. He was able to ambulate on his own, and he was actually discharged with orthopedics and rheumatology follow-up. The concern was that given the family history in his brother of juvenile idiopathic arthritis and the kind of fuzzy area with his father, whether it was rheumatoid or viral, they wanted them to follow up with the rheumatologist.
Mhm.
And I actually just recently checked that note because he saw the rheumatologist yesterday or a few days ago. And the note said that his pain was improving and that he's continued to take his antibiotics. And that is where the case is at today.
Yeah, I would see this, I mean, it's always good to check the other things. You don't want to leave any stone unturned, but this is more of an acute. It would be interesting to know, I mean, like strep is usually one that gives us kind of more this picture, and and that's definitely covered by the levofloxacin.
Great.
So Dr. Laila, if you could give like 3 takeaway points about septic arthritis, what would you say for us?
Okay, so for acute septic arthritis is definitely going to be your history and your physical. So your physical exam, any joint that doesn't have, cannot do a range of motion should be evaluated with an arthrocentesis. In the age groups that are between 20 and 50, which reproductive age, if you want to put it that way, I always check JC and HIV, just because they're very predominant, and especially if they're monoarticular. And for those that take internal medicine boards, gonococcal arthritis is one that they love to test on. It's and even in ID boards, but in internal medicine they do too. And then it's I guess the third is looking at the most common infection agents are staph, strep, in that order, and then treat accordingly to that.
And I guess another takeaway home point would be like do the arthrocentesis first before giving antibiotics.
Yes. So yes, that is a good point. Yes, Rafa, that's a great point. Yes. So it's the same thing that happens with the lumbar punctures. Is get the blood cultures, get whatever you need before you start, because strep is notoriously easy to eradicate with just a whiff of antibiotics. It is classically that way. So that's the part. Yeah. And as I said, management, I would have approached this a little differently, than the way it was. I just think that it was, we could have skipped some. And the family history, it's interesting because he doesn't have any other like autoimmune issues.
Right.
You don't have other joints. He doesn't have spondyloarthritis. I mean, yes, it is a 21-year-old who comes in with a septic hip, but it's not that unusual,
Oh, Dr. Laila, thank you so much. Today we learned this not only management, but clinical reasoning, and like we say with Maria all the time, like diagnostic management stewardship, right? Like what labs should I ask, what labs should I skip, that it's not gonna be good for the patient or not necessary for the patient. So thank you very much. So maybe Kara, can you go with the teaching points?
Of course, thank you so much, Madalena, for the case and Dr. Laila for all these amazing pros. So we started with a very young adult with left hip pain. So Dr. Laila started with categorizing uh, about infectious or not infectious etiology. So for infectious etiology, she said that we have to think about sexually transmitted diseases, especially if it is unilateral joint infection, for example, like gonococcal, which usually presents in one joint, and also about the epidemiology, as this patient had a relative near the East US coast. So we have to think about Lyme. Also, we have to think about some fungal or parasitic infections. And then we have to think about non-infectious diseases because this is also a young patient. So this patient could have some trauma, fracture, for example, or maybe this patient was not previously, if this patient wasn't previously healthy, maybe this patient had a sickle cell disease and some presentation with a vascular necrosis. Also, we have to ask if this patient had previous infections like otitis media or sinusitis, because this could mean a recurrence about some immunodeficiencies. Also, a very a pearl that I will never forget is that if we have a patient with a limited range of motion, this patient should be evaluated with an arthrocentesis before starting antibiotics, because we want to avoid masking the real diagnosis. So we found with the vitals and the HPI that this patient has a septic joint disease. So the question next was, how can we move forward? And we have to and we have to take some labs like white blood count, CRP, ESR, and of course arthrocentesis before starting antibiotics, and so some images, for example, and an X-ray for the localized zone affected joint. Then we can start empiric treatment, in this case, Vanco and Septic, because these two can cover the most common etiologies. Something very curious I just learned is that Redman syndrome, now it is called vancomycin fusion syndrome or infusion-related rash. Then after we had the results for the infectious for the arthrocentesis, we can think about an infectious etiology if we have more than 100,000 nucleated cells or purulent appearance of the discharge, or gram positive or gram negative or any other bacteria present there. Then we can't rule out HIV, gonococcus, or chlamydia etiology. Also, we cannot rule out mycoplasma because they can cause recurrent joint infections. Also, we have to think about Propionibacterium, and well, now called Cutibacterium agnes, because this can also be found. However, this is also covered by vancomycin, which the patient was given. And some additional tests, which I learned today also, is that there are some available rapid tests for blood fluid, like in this arthrocentesis, that can cover more than 10 different organisms, and alpha defensin, which is elevated in joint infections, especially in prosthetic joint infections. And one amazing pearl again is that when we want to know what was the what the physician, for example, traumatology, found when they do the procedure, we have to check the OR notes, because they have the more detailed information you want to get. So you have to check those notes. Thank you so much again for this case.
Thank you, Dr. Laila. Thank you, Madalena. And remember, everyone, to not give antibiotics if you're doing LP and arthrocentesis, and also check HIV if your patient is sexually active and young, okay?
Yes.
So make Dr.
before we
Laila
go,
happy.
there was a question in the chat about about septic arthritis and vesicles and other types of arthritis. So vesicles, it's an interesting part. So you always see that when there's endotoxins or exotoxins, and so you can have like a bullae. Often it's seen with staph, but that's, when there you have more of a toxin. Meningococcal disease can cause that, but, and then obviously shingles and things like that. What happens when you have the bullae is then they don't want to go put in a needle because it's an infected site, and so it makes it difficult. But I don't see the skin as a part of when evaluating, a joint, as more as that is the secondary to whatever bacteria is being produced there. So
Wow.
I didn't want to, leave that on there a little bit. Yeah.
Drop the
I know
mic.
sometimes the skin talks to you, but not all the time.
No, it was like a drop the mic moment. Thank you. Hope to see
right.
everyone. See you, everyone. I hope everyone had a nice session. And
Thank you.
have
No,
a good
thank you
night.
for the invite. Happy holidays.
Thank you so
Happy
Happy
much.
holidays.
too. Take care. Always.
Bye.
Bye.
Bye-bye.